Well, good afternoon. My name is Jody Scholes. I'm your instructor for the MBLEx review course. And we were just having a lively conversation about the MBLEx and how the MBLEx actually has nothing to do with your ability to be a great massage therapist. It is simply a test. It's simply a test that you get to prepare for. You get to calmly and confidently prepare for a peaceful passing of the MBLEx. But today we're talking about pathology, and we're going to do our class in 3 parts today. The first part is going to be a test-taking strategy. The second part of class is the learning. We're going to go over pathology today, and I've got a bunch of different conditions to walk you through. Pathology is just a fancy way of saying disease or dysfunction. And so we're going to look at a few dysfunctions and what those look like. And then our third part of class is dissecting questions, where you get to apply the knowledge that you've learned to taking questions. And remember that it is important to get to the best answer, right? So it's not just about finding the right answer. It's about getting to the best answer. And that is a test-taking strategy I want to share with you today. So this is the first part of our class, this test-taking strategy. And that is, I want to explain to you something very unique about the MBLEx. And that is that in the answers, so on your MBLEx test, you will have either 3 answers or 4 answers to choose from. In those answers, there are always distractions. The test questions are written to include something called distractors in the answers. Something to distract you into thinking it's the right answer. So what I was saying is that on the MBLEx, each question is written with distractors. It's going to try and convince you to just grab the answer that looks right. And so what we're going to practice today, and what we practice every week, is dissecting questions. So dissecting questions gives you a chance, gives you the opportunity to pick the wrong answer. Yeah. So when we do our dissecting questions, I expect that maybe you're going to pick the wrong answer because I've put distractions in each of the questions. Yeah. I want to simulate what you're going to be experiencing with the MBLEx. So each question is written. Yeah. All right. Just want to make sure the recording is clear because I'm seeing some feedback there. So in any case, just want to make sure that you understand when we're dissecting questions that there have been answers put in there that are going to look right, but they're not the best answer. And so that is my test-taking strategy for you today, to remind you that the MBLEx is going to offer you answers that are going to look right. Sometimes you're going to have 4 right answers. You got to pick the best one. Yeah. So don't freak out if you're in that situation. I say don't freak out, but stay calm when you're in that situation, and just know you can breathe. You can come back to the present moment, and here you are. And you can get to the best answer. I promise you. We're going to practice. So you ready for a little learning? All right. Let's go into part 2 of our class for today, and that is about pathology. This is stuff you learned in massage school. Let's hope. All right. There we are. So here we are with Pathology for Massage Therapists. This is a review. Some of the subjects I'm going to get into are, we'll go a little deeper. And just as a good reminder, this course is actually meant to be a review, but some of those topics we will do a deeper dive. So welcome back to many of you, and welcome if you're here for the first time. Here's what we're going to cover today. So we're going to be talking about some tendon disorders. We're going to touch on Achilles tendonitis and both golfer and tennis elbow. Those are tendon disorders. Then we're going to jump in and do some postural deviations, osteoporosis, what is proper posture. Then we're going to talk about arthritis. We're actually going to talk about 3 types of arthritis today: osteoarthritis, rheumatoid, and psoriatic. We're also going to cover sprains and strains. We're going to talk about whiplash. And given that we have the time, we're also going to discuss carpal tunnel syndrome. Here we go. These are all considered pathologies. So tendon disorders. In fact, let me just mention again that all of these are considered pathologies. And pathologies is just a fancy way to say dysfunction or disease. So if somebody has a pathology, it's typically a dysfunction or a disease. So what are some examples of tendon disorders? And that's a word that you may see on your MBLEx to try and throw you off. Tendon disorder. Is that even a category? It might be. So examples of tendon disorders: Achilles tendonitis, tennis elbow, golfer's elbow. These are all pathologies of a tendon. So a tendon disorder. Let's take a look at Achilles tendonitis. Achilles tendonitis occurs right here at the base, the posterior distal end of the lower leg. So it's at the distal end of the soleus. And go ahead, if you're sitting down and you're not driving or operating heavy machinery or doing a massage, go ahead and find your own Achilles tendon. Yeah, go ahead and just give it a little pinch test. Is it tender? So you're going to be pinching right around where it says number 4, right there. And that is a lovely way also for you to use a diagnostic tool. We're not diagnosing anything, but it's a tool that you can use to see if your clients have tenderness in their Achilles tendon. It's just a little pinch test. Yeah. So I mentioned that the Achilles tendon is at the distal end of the soleus. If you followed that Achilles tendon straight up, you would go under the gastroc and it would turn into the soleus. There are 2 muscles in that lower leg. The gastroc is the big meaty one that's with the heart-shaped muscle. That's a dual-headed gastroc. So that's why we get those 2 heads, the lateral head and the medial head here. But when you go under the gastroc, you get the soleus. The soleus, if you peel away, a deeper muscle is the soleus. And the Achilles tendon attaches the soleus to the calcaneus. So I like to mention in doing the work, in doing the body work, that there's a concept called reciprocal muscle groups. And reciprocal muscle groups are muscles that are like the bicep and the tricep, like the hamstring and the quadricep. So they don't work together. They work independently, but they reciprocate. So the bicep flexes the arm at the elbow joint. The tricep extends the arm at the elbow joint, flexes the arm, extends the arm. They can't work together. And that becomes important later on when you're studying sports massage or orthopedic massage. But the reciprocal muscle of the soleus is the tibialis, the posterior tibialis. And so it's lovely to work this front of the leg. So to work on the lateral side and then also on the medial side. You may or may not get a question about reciprocal muscles on the MBLEx, but I want you to be familiar with the concept. And if you want to know how to find the posterior tibialis, send me a message in the patron message board. Happy to explain. But here we go, the Achilles tendon, Achilles tendinitis, I-T-I-S, that suffix, that's the suffix of a medical terminology, right? The end, I-T-I-S, means inflammation. Let's take a look at tennis elbow. So where do people feel it? Tennis elbow is a pathology of the lateral side of the elbow. It's also known as lateral epicondylitis. So lateral epicondyle, this is where people are feeling it. So let's take a look. Let me compare this to golfer's elbow. So lateral epicondylitis, golfer's elbow. Oh, before we go to golfer's elbow, this is a chronic overuse injury. It's something where you'll feel tenderness on the lateral aspect of your elbow. And go ahead and palpate your own. Technically, it's the lateral epicondylitis of the humerus, so the long bone of the upper body, long bone of the arm. And so you're going to feel it. You can just, I like to cup my elbow and just turn the lower arm. See if there's any tender spots in there. And this pathology is not only caused by tennis, it can be caused by cleaning, it can be caused by typing, it can be caused by a lot of just any overuse of the lower arm. So even like cleaning, yeah, but it's a chronic overuse injury. Compared to golfer's elbow, which is the medial epicondyle. So if you look here and think about anatomical position again, this golfer's elbow is actually pinky side. So golfer's elbow is actually on the pinky side. And one of the ways I remember golfer's elbow is that sometimes when people golf, they actually interlock their pinky with their first finger. And so pinky side, medial, because in anatomical position, we are standing forward, palms facing forward. Pinky side is medial. Medial closer to the midline of the body. So lateral is thumb side, medial is pinky side, because again, that anatomical position, lateral, further away from the body, from the midline of the body. Thumb side. Medial, pinky side. So medial epicondylitis, if you grab that, if you grab that golf club. And another thing is you can't do that with tennis. Like you can't cross your fingers in tennis, right? Even if you have a double-handed backhand, you're not interlocking your fingers, but some golfers do. So just another way to remember golfer's elbow. The treatment includes the release of the flexors of the forearm. So flexors of the forearm, because typically this is what is causing the overuse, something with this motion, the flexors of the forearm. Rest is encouraged as well. And you can massage with, moderate cross fiber. I really like to just get in there. But I don't think you're going to see bodywork questions on the MBLEx, to be honest with you, how to treat. You may see session adaptations, but that's another lesson on client assessment, reassessment, and treatment planning. So, but knowing the anatomical location of golfer's elbow, medial epicondylitis. All right, let's change gears. Well, let's take a look at osteoarthritis, rheumatoid arthritis, and psoriatic arthritis. Do you know the differences? Okay, osteo is the most common form, osteoarthritis. And it is a result of wear and tear on the body. Osteoarthritis, it can damage any joint in the body, but most often we're looking at knees, hips, finger joints, sometimes the spine. But because of wear and tear, you can see here, there's some erosion. There's some erosion of the cartilage. It's a mechanical problem. Let's take a brief look at the knee and look at where we have cartilage. So the kneecap has these two lovely, they're kind of C-shaped, right? C-shaped, there you go. Pieces of cartilage called your meniscus. Have you heard of the meniscus? I bet you have. Yeah. All right. And they're kind of a shock absorber. And you may have even known a family member or even a client who had a minor tear in their meniscus. Minor tears actually can heal on their own if they're minor. This is also a really great reason to work the knee. Oh, so nice. People love it when you massage their knees. It's crazy. We'll talk about that another time, but it's really, try it sometime. And next time you get a massage, ask them to work your knees. And working these areas is just such a lovely, because we've got this lateral collateral ligament. We've got the medial collateral ligament. So where do you think those are, huh? Lateral collateral ligament out here, lateral, attaching from the distal end of the femur to the head of the fibula, the little bone. Here's the medial collateral ligament. That's medial. So, but here's that meniscus. This is also, all this white stuff is cartilage. Yeah. So the meniscus actually cushions and stabilizes the knee. And typically when we have an injury or a problem with the meniscus, there's been some type of shearing, some type of movement where the femur has gone one way and the tib fib has gone another. Now that happens a lot in sports, right? And it can happen a lot if there's lateral movement. So again, remember as massage therapists to go ahead and address the knees. There's a lot of yummy stuff to work on in there that can really benefit from massage. But now let's look at how that knee anatomy is compromised by osteoarthritis. So here's that healthy cartilage. There's normal joint space in there. And here's what starts to happen when there's loss of cartilage. When people say bone against bone, their cartilage is starting to wear down. And sometimes that can cause bone spurs. It definitely creates some narrowing in the space. It's just, there's not a lot of mobility in there. And osteoarthritis, because it's a wearing down over time, those symptoms can be managed, but that process, that wear down, that usually does not reverse. It's not like we're growing new cartilage. So this is a wear and tear type of thing, and it affects sometimes just one joint versus the other. It doesn't have to be bilateral. And again, this is the most common type of arthritis. Oh, and staying active helps to prevent osteoarthritis, and it even may slow down the progression of the disease. We'll talk more about prevention in a moment. Let's take a look at another form of arthritis, and that's rheumatoid arthritis. This is not wear and tear. This is an autoimmune disorder. So the immune system is actually attacking the lining of the joints. And sometimes, if it gets really bad, if rheumatoid arthritis gets really bad, it can attack other parts of the body. They don't know what causes rheumatoid arthritis. Some people say it's genetic. Osteoarthritis is genetic. You can't give it to yourself. You have to be have a predisposition. But with rheumatoid, they're not sure what actually causes it. Let's take a look at some of the effects of rheumatoid arthritis. The immune system is attacking your tissue, usually just lining the joints. Medication has really improved for rheumatoid arthritis and can absolutely keep the symptoms at bay, control the progression of the disease. But sometimes rheumatoid arthritis will create gut problems, digestive problems, some scarring, lots of inflammation in the joints. But the options for treatment, if someone is diagnosed with, and there's a very specific marker for rheumatoid arthritis, they can track that in your bloodstream. But typically there's some lifestyle changes, some dietary changes, may do physical therapy or occupational therapy, depending on the stage of the degeneration. And there's, of course, there's medication. So just as a review, it's a chronic inflammatory condition, an autoimmune disorder that can affect more than just your joints. Your immune system is actually attacking the lining of your joints. Not you, but the condition. Sometimes this rheumatoid arthritis progresses and it can damage more than just the joints. And it's basically a misfiring of the autoimmune system, and it starts to attack the body's tissue. Let's just do a quick comparison. This is a healthy joint. This is evidence of rheumatoid arthritis. So it not only has the bone erosion, it's got swollen, it's inflamed, the cartilage is wearing away, there's reduced joint space. That looks a lot alike. But again, medications have progressed dramatically over the last 10 years. And rheumatoid arthritis used to be a really devastating diagnosis. Nowadays, actually, it really can be controlled pretty well. And here's more good news. Research shows that massage helps to control the inflammation, helps to decrease the systematic swelling that is sometimes present in rheumatoid arthritis. Here's a quote. Many clients who continue regular massage therapy have discovered their pain not only decreases, their activity level increases, and helps to tolerate the pain. So massage is great. Osteo, rheumatoid, and even psoriatic arthritis. Have you heard of psoriatic arthritis? Well, psoriatic arthritis is a condition that's linked to people who have psoriasis. In another lesson, we learned about psoriasis, but psoriasis is this red, kind of flaky skin. And there can be a rash, it can affect the fingernails, the toenails, but psoriasis contributes to psoriatic arthritis. And so psoriatic arthritis is similar to RA, rheumatoid arthritis. You'll see sometimes in research documents, they don't write out the whole word. They just write out RA. And you may see that on the MBLEx. So RA refers to rheumatoid arthritis. Psoriatic arthritis usually is more so in the hands, fingers, and wrist. It doesn't affect as many joints or as much tissue as RA does. And as I mentioned, RA has some markers that are antibodies that tells you it's systemic. Psoriatic arthritis doesn't have those markers. And here's more research that shows massage therapy is excellent for arthritis. In fact, it says people with psoriasis report stress as one of their condition's triggers. Stress triggers episodes of psoriasis. Can you believe it? I know. It makes sense, right? Stress contributes. And so when we can manage the stress, we can manage the conditions. And so, yes, and so flare-ups like that are few and far between with regular massage therapy. Okay. On to our next pathology. Let's take a look at some postural deviations. Some postural, what? Yeah. So postural deviations does mean deviations in posture. Deviations, they've deviated from the norm. And there's different types of postural deviations. We're going to speak specifically about osteoporosis in a moment. But here are some common postural deviations. Problems. I don't like to give my clients problems, right? They come in with enough of their own problems. So I like to say they're postural deviations, things that are a little bit different than the norm. All right. So we'll talk about ideal posture in a moment, but here you can see this is a bit of a sway back, a posterior tilt to the pelvis. So posterior tilt to the pelvis. Go ahead and tuck your tailbone under. That's a posterior tilt to the pelvis. So we talk about the pelvis as if it's a bowl or a cup. So if it was a bowl and we were going to tip that bowl backwards, if we were going to pour the soup onto our lap, backwards. So tucking your tailbone under tips your pelvis back. And so if you've got an engineering mind, good on you, but I need the visuals. So got it. It tips it back, tilts under, and that means it's a posterior tilt to the pelvis. Your bowl of soup tips back. You're pouring it out the back. That's what's happening to the pelvis. Tailbone goes under. The next postural deviation, they call a military back. Chest is out, right? You can see in this example here, the chest is sticking out, and that can cause an anterior tilt. So that means you got that kind of duck's butt, right? So shaking your tail feathers. If you stick your tailbone out, sticking that tailbone out, that causes an anterior tilt to the pelvis. So your bowl of soup, you're pouring it out in front of you. Tailbone goes up, pelvis tilts forward. All right, then another postural deviation would be considered a flat back. We've got a kyphotic or lordotic curve. So kyphosis is what we're going to see as a condition of osteoporosis. Kyphosis is specifically in the thoracic region. Don't know why it's called kyphosis, because in the lumbar region, it's called lordosis. So L, lumbar, lordosis. So lordotic curve, that deep curve in the lumbar area. So the kyphotic curve here is in the thoracic region. and the lordotic curve in the lumbar region. And this is a forward head. And, Americans, well, maybe all over the world, but certainly in America, lots of forward head position. Check yours right now. Put 2 fingers on your chin. Push it back. So is your head over your neck? Is it forward? So typing on the computer, right? Driving a car. Every now and then, just go ahead and gently bring that head back. If you get a lot of neck strain, if you have some like lower occipital region headaches, tension, check that head position. We often are in a forward head position. One other way to think about that is to think about a string attached to the top of your head, lifting you. Just go ahead and lift yourself up. You can go. You don't need to whistle. But it just, again, it elongates your spine, decompresses your spine, and that allows you to check in with your own posture. Ideal posture is different for everyone. So a neutral spine is not always possible with your clients. And so please be cautious about setting expectations for a client that they can't meet. And we're going to see a different type of pathology in osteoporosis in a moment. But here's an example of some postural deviations again. Shoulder rounded, the hips are forward, the knees are locked. And so these are just some examples of, I would say, good posture and better posture versus ideal or poor. So let's take a look at osteoporosis more specifically. This is a condition of the spine. Sometimes people, and you can see here's a healthy spine. And we start to see the kyphosis. And we start to see, and it becomes a very rigid spine and also a very brittle spine. So back pain, some people lose height because of the compression of the spine or because of their forward position. They get a kyphosis or a hunchback appearance. And osteoporosis can also sometimes there are more common bone fractures with people who have osteoporosis. Why are there more common bone fractures? Well, let's take a look at the condition of the bones, which we'll do in just a moment. So 2 different conditions, 2 different stages of osteoporosis. Osteoporosis is a medical condition. The bones have become brittle. They're fragile. There might be a loss of tissue. Typically, this is a result of some type of hormonal change going on in women. It can happen in men, but not often. Or it's a deficiency of calcium or vitamin D. But it's a long term. It's been happening. Osteopenia looks similar, right? Similar words. But this is the early stages of osteoporosis. If someone's been diagnosed with osteopenia, then they still have an opportunity to do some work, which we'll talk about in a moment, to not get to osteoporosis. So the reason that the bones are more brittle is because they have changed in their density. So this would be a normal vertebrae. And then look at this osteoporotic vertebrae. See all the holes? It's actually getting lighter. It's getting thinner. Yeah, and that is why the bones are more susceptible. And you can see again this kyphotic curve affecting the thoracic region. So again, a little bit closer look at normal bone tissue, normal bone density, and osteoporotic bone density or osteoporosis in the bone. So risk factors, who gets it? Women mostly. over more in their perimenopausal years. So maybe 50 and older. This says 45 and older. Asian Americans are a little bit more likely. They have lighter bones in general. And also if you have a small frame. White, light skin, blonde hair, kind of Germanic type of build. These are some of the risk factors. And so what do you do to avoid osteoporosis? Oh, we talked about the risk factor. Hey, remember, diet's low in calcium and vitamin D. One of the things you're going to do is get your vitamin D, right? Where do we get vitamin D? We get vitamin D from fortified milk. We get vitamin D from the sunlight. Some forms of milk have vitamin D. It's in America, almost all the milk is enriched with vitamin D because it doesn't occur a lot in food. But you want to, of course, calcium, right? Because you know from growing up that calcium gives us good bones, but also vitamin D. So, and most people don't even know that their bone density is low until they break a bone. So, we as massage therapists know the categories, the risk factors, and so what do we do? We'll get to that slide in just a moment. What do we do when we have a client with osteoporosis or osteopenia? Well, we can recognize clients who are at high risk, females, menopausal, light-skinned, small-framed. We can ask if they've had a bone density test. When we have a client who has osteoporosis, there will be session adaptations, especially if they have a kyphotic curve. You may need to place a pillow under their head. You may need to brace them under their shoulders, so putting a pillow under each shoulder, little pillow, or even a rolled up towel. Did you do that? Did you use that technique in massage school where you put towels or small pillows under the shoulders? It's especially helpful if you have a very full-figured woman. If they have a large amount of breast tissue, it's lovely to put a rolled up towel, hand towel, or even regular towel under each of their shoulders to give them a little bit more space. Yeah. So when we have someone with osteoporosis, we're not going to be doing deep work around the spine. We know those bones are fragile, and we want to use relaxation techniques versus deep tissue techniques. And also we can talk to the client about doing things that will encourage the preservation or the building of bone mass. And so what is that? Consume enough calcium, get enough vitamin D. Oh yeah, there's supplements for vitamin D as well. And exercise. So the specific type of exercise that these women will need to do is weight-bearing exercise. That, hands down, all the research shows when a woman who is fragile, small-boned, Asian American, white, maybe has a family history of osteoporosis, when they do weight-bearing exercises, they do not lose bone density. They keep their bone density. Pretty cool, huh? Yeah. These are things that you could be tested on the MBLEx in the sense of understanding the pathology of osteoporosis, what's actually going on, the bone density loss, or the session adaptation. So be careful with those questions. Ooh, all right, we're going to change gears. And I believe we're going to go into a little whiplash. Yes. So whiplash, why do we care about it? We care about it. Well, what is it? Whiplash is a snap of the neck, and you see here, the cranium has been forcibly gone forward. It has forcibly gone forward and snapped back. That is a whiplash, and so like cracking like a whip, right? Now, what causes whiplash? Typically, it's a rear end auto accident. If they've been in an accident, side impact, front impact, not as much. But with the rear impact, MVA, motor vehicle accident, so rear impact is what causes that snap of the head forward and the snap back. But this injury, the whiplash injury, can come from a sports injury. It can come from playing soccer, playing football. It can be from being hit, physical abuse, or trauma, some type of other trauma. But most commonly, we see this diagnosis with a motor vehicle accident, rear impact. All right, so why do we care? Isn't massage great, for musculoskeletal injuries? Certainly, it is. And I enjoy treating clients who have had a challenge with whiplash. However, it is contraindicated to do massage therapy on a client who is within 72 hours of their incident, whether it be sports, motor vehicle accident, whatever. It's contraindicated to do massage for 72 hours unless they've been cleared by a doctor and cleared by a doctor for massage. Now, why 72 hours? Stick it in the chat. Been talking at you for half an hour already, and we haven't even chatted in the chat. Why 72 hours? Oops. Question mark. All right. Tell me in the chat, why are we waiting 72 hours? I'm happy to take a little break. Oop, we have a response. Pain level? Yes. What about the pain level? Swelling? Yes. What about the swelling? We need the swelling to go down? Yes.
Dopamine levels? Dopamine levels?
Dopamine levels? Yes. It's dopamine is something we'd be considered, but adrenaline. So the adrenaline and the dopamine, all of those hormones. Oh,
yes, that's what I was. Adrenaline. Yes.
Exactly. They may not know how bad it is. Exactly. So yes, the pain level, the swelling, and they may not know how bad it is, because when we have a motor vehicle accident, a trauma, any type of trauma, our sympathetic nervous system kicks in, our fight or flight, right? So whatever it is. And so our system releases dopamine, adrenaline, cortisol. All of those hormones can mask pain. And they can be in the system up to 72 hours. So they may not know how bad it is. You may even know someone or have had the experience yourself, where you walk away from an accident and you can't believe, wow, I feel okay. And maybe you've had a friend who said, oh, I got into an accident, but I think I'm okay, only to wake up the next day or in 2 days and be like, oh my goodness, my body, I feel like I got hit by a truck. You maybe got hit by a truck. So that stays in your system, and until it cleans out, you won't realize, your client won't realize the extent of their injuries. So that's why they need to be cleared by a doctor, have a doctor's note okaying them for massage, or we wait 72 hours. Always best to wait 72 hours. All right. Next, we go into sprains or strains, and this is super easy. And I cover it just because it is often on the MBLEx, the difference between a strain or a sprain. So what's the difference between the two? All right, so a sprain, they're going to look similar, but a sprain, you can see here, it's a stretching or a tearing of the ligaments. And ligaments are those fibrous bands that attach bones together. So ligaments attach bones to bones, and that is a sprain. A strain, S-T, see how I spelt that here? A strain is the stretching or tearing of a tendon. So the muscle is attached to the bone with a tendon. Strain, ST, tendon, T. Strains are of the tendon. Sprains are of the ligament. And sometimes when they are badly strained or sprained, you'll see this, this pooling of blood. That doesn't mean they're internally bleeding. That just means they've ruptured a part of that tendon. It doesn't mean the tendon is detached. It doesn't mean the ligament is detached. It means they've had a very bad strain or a very bad sprain. All right. Carpal tunnel syndrome. I believe this is our last category before going into dissecting questions. Quick review of carpal tunnel syndrome, another pathology. Where in your body is your carpal tunnel? Where do they feel it? Where do your clients feel it, huh? Right? Carpal tunnel. In through here. So carpal tunnel syndrome is first detected because it causes this numbness, tingling, sometimes pain in the fingers and in the wrist. Many times, carpal tunnel syndrome has been caused by overuse of flexion of the wrists or overuse of extension of the wrists. So we'll show you the pathology in just a moment, but you see here someone typing on a keyboard. Very common reason to have a compacted carpal tunnel. Let's look at the anatomy. So your carpal bones form this really cool arch. I like to think of it like a stone bridge. So if you've been to a park or you've been to Europe, it's like this stone bridge. And these bones, you've got 8 carpal bones. And I like to remember 8 carpal bones because have you ever seen anyone with a tattoo of the infinity symbol right here? That's kind of it's not an uncommon thing, but the infinity symbol is also the number 8. It looks like the number 8, right? So you can just think of 8 carpal bones with an infinity tattoo on the wrist. So this tunnel, it's actually a tunnel caused by this arch here, this beautiful arch in the carpal bones. But what happens is if we compress it, if we extend it and get it tight, that tunnel can actually decrease in size. And all the same nerves and blood vessels and ligaments and tendons, they all still need to fit in the tunnel. But if it gets tight and short, there's a carpal ligament that goes across here like a wristwatch. And when that gets tight, when it shortens, it compresses the ligaments, the nerves, the blood supply. It compresses that tunnel. And that's what starts causing the zinging. The carpal tunnel syndrome is caused by the compressed nerve in the carpal tunnel, but that's happening because the carpal ligament is shortening, usually due from saying like or typing. Oh, am I done with that? Okay, so basically, massage techniques include going ahead and warming up that carpal ligament, getting in there, treating that lovely thumb area around the saddle joint. Lovely opening up, warming up of that carpal ligament will absolutely regain space. In fact, that's what carpal tunnel surgery does. It severs this ligament to try and make space. But guess what happens when it heals? Scar tissue. And scar tissue can create like something else now that needs to fit in the carpal tunnel. You know, and it can, if that scar, if it's a person who lays down a lot of scar tissue, that can again create pressure, can create more pressure on that median nerve, on that nerve, that median nerve. All right, that was it. So we can take a little stretch break here, This was my kind of funny stretch break. So feel free to rotate your spine, rotate your shoulders back, rotate them forward. Yeah. Ready to dissect some questions? All right. How is vitamin D obtained? A, diet and sunlight. B, all forms of milk. C, supplements. We don't make it in our body. D, foods that start with D, such as dairy, dark chocolate, and dragon fruit. How is vitamin D obtained? So in our dissecting of the questions, can you eliminate one wrong answer? Do you know one of those answers is definitely not right? What answer is it? Stick that in the chat. Yes, exactly. Thank you, Valerie, for putting that up there. And also thank you, Lona, Lauren. Yes, 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 yes. Good. All right. So we know letter D, that's not right. We don't get vitamin D from dark chocolate. No. Other things you get from dark chocolate. All right. So that leaves us 3 answers to choose from. Which do you think is the best answer? How is vitamin D obtained? Diet and sunlight, all forms of milk, or supplements? Let's look. We got lots of answers in the chat. Ooh. Good. And okay. Good, good. Oh, you guys weren't fooled. Most of you weren't fooled. Good. Nice work. Nuyo, yes. Angie, yes. Lona, yes. Lauren, yes. Valerie, yes. Good, good, good. Because guess what the correct answer is? Diet and sunlight. Why isn't it milk? Vitamin D in milk, right? Yes and no. Not all milk is fortified with vitamin D. Milk is a great form of calcium. But the best answer here is diet and sunlight. Sunlight is where we get most of our vitamin D. Our body makes it when we have the sunlight. Diet and sunlight. Diet includes eating it, drinking it. So our diet and sunlight. That's why A is the best answer. So if A was not there, and it didn't say all forms of milk, milk is often fortified with vitamin D. So just be careful. Oh, there we go. Vitamin D is converted in response to low levels of plasma plasma calcium. Yeah. So low levels of vitamin D deficiency also causes rickets. So rickets is a deficiency in vitamin D. Rickets is brittle bones. And also osteomalacia, which is soft bones or they curved bones. Just a few more vocab words for you there. Ooh, how can one prevent osteoporosis and osteopenia? A, long distance running. B, walking. C, you can't really avoid it, it's genetic. D, weight-bearing exercise. Can we eliminate one wrong answer? I'm thinking you're going to be putting the right answer in there. Yes. Yes. Okay. Yeah. Let's get rid of it. Angie says, let's get rid of A. Let's get rid of A. We know long distance running is not a good idea for people who have osteopenia, right? You know, we don't want to create more problems for their bones, more pressure, more wear and tear on their bones, right? All right. Let's see. Ooh, I see some correct answers coming in. Good. Yes, yes, yes. All right. Tanya and Valerie already put their answers in the chat. Are you ready? Ooh, we got a few more correct answers. Yes, Lona. Yes, Angie. The best answer in this particular question. Thank you, Nuyo. You got in there. Boom. Weight-bearing exercise. Yes. This is within the scope of your practice as well. to ask your client if they are in the category of susceptible to osteopenia, osteoporosis. It is within the scope of your practice to go ahead and let them know, hey, did you know that weight-bearing exercises really help to prevent osteoporosis? You're just giving them the research. That's not your opinion. So to prevent osteoporosis and osteopenia, you want to avoid activities that could make it worse. And you can look at lifestyle modifications as well, like a Mediterranean diet, higher intake of calcium and vitamin D. And then also, depending on the stage they're at, just making sure that the person doesn't fall, especially in your office. That means, like, I think I can say this, just like, don't have shit laying around your office. Don't let it be cluttered. If you trip over stuff, your clients could trip over stuff. So neat and clean, okay? Yeah. All right. Next question. What is the difference between rheumatoid arthritis and osteoarthritis? A, one is in old people, the other is in young people. B, osteo is a degenerative disease. Rheumatoid is an autoimmune disease. C, with osteoarthritis, you can tell when the weather's going to change, but with rheumatoid arthritis, you've heard it all the time, all over. And D, they're basically the same, right? I like what you're putting out there. Let's get rid of one wrong answer. And I'm going to give you this one just because you know they're not basically the same. They're different. Good. Yes, Nuyo, we eliminated the wrong answer. I see. Valerie, Tanya, Lauren, Lona. Yes, yes, and yes. Good work. The best answer, letter B. Osteo is a degenerative disease. Rheumatoid is an autoimmune disease. So that's the big difference, is that osteoarthritis is still genetic, but it's a degenerative disease, meaning it's wear and tear, whereas rheumatoid is an autoimmune disease. Again, as a reminder, rheumatoid arthritis is a disease in which the immune system attacks the joints, beginning with the lining of the joints, and sometimes goes on to attack other parts of the body. Next question. Ooh. What is the clinical name of tennis elbow? Is it A, medial epicondylitis, B, thoracic outlet syndrome, C, carpal tunnel syndrome, D, lateral epicondylitis? Ooh, people are remembering. You are learning today. Good job, Nuyo. Good job, Tanya, Valerie. Yes, Lauren, you want to get rid of C? You bet. All right, let's get rid of, we got rid of B, thoracic outlet syndrome. You can get rid of carpal tunnel too, right? So it's either medial or lateral. And let me just check the chat one more time. I want to make sure. Yes, Angie. Yes, Makia. Yes, Lauren. And letter D is correct. The best answer is lateral epicondylitis. So tennis elbow, so anatomical position, so farthest away from the body, thumb side. Yes, good. Remember that medial epicondylitis, pinky side, right? Closest medial epicondylitis, closest to the midline of the body. And that's going to be pinky side. Yeah. Okay. Oh, what is the wait time for whiplash? A, 24 hours. B, 48 hours. C, it's an absolute contraindication. They have to see a doctor. D, 72 hours. What is the wait time for whiplash? Oh, bang, bang, bang. Tanya, yes. Valerie, yes. Lauren, good. Lona, Nuyo, yeah. Yeah. All right. Let's get rid of one. Whiplash is not an absolute contraindication. If they've had it, they actually may be sent by their doctor to get massage. Most of you have already put in the best answer. And the best answer is 72 hours. That is the wait time. Yes. Let's see. Yep. So we got rid of the absolute contraindication. They have to see a doctor. With the wait time, look at the question. What is the wait time? So it's true. If they've had whiplash, that is an absolute contraindication. You cannot work on them unless the wait time has expired. If it's been 72 hours, then you can. All right. Woo-hoo. Yes, you're done. You did it. You made it. Great work. Great work. That was a lot of different conditions. Let me go ahead and stop the share. And all right. I know. Does your brain feel fuzzy? Good work. If your brain doesn't feel fuzzy, keep on keeping on. Jump in, then go do a class, go listen to another recording, go do a class in the Patreon site, on the Patreon site, or reward yourself for a job well done today. Very, very good work. These were a lot of different pathologies and a lot of different angles to consider on these pathologies. But now, when you see them on the MBLEx, you will feel so much more comfortable in addressing these different types of conditions because you understand the pathology. You understand what's going on with the condition, and that will help you to answer the question about how to treat the condition. So thanks for being here. I'm going to wrap up this recording by reminding you my name is Jody Scholes. I am your instructor for the MBLEx review course. We're here every week. If you'd like to join us on Thursdays, 12 o'clock Eastern time, we are studying to pass that stinking MBLEx. Yes, rest. Yes, exactly. Yes. And this is happening. And I'm challenging you if you're within the sound of my voice to go ahead and register. Unless something's going completely haywire in your life, when you register and you get your authorization to test, you have 90 days. I challenge you to give yourself motivation, knowing that within 3 months, you can be ready to take the MBLEx. So, won't that be something when you pass the MBLEx? I can't wait to celebrate with you. So, before we wrap up class, here's a view of the Patreon community. Here's the landing page. This is where we go to celebrate. This is when somebody passes the MBLEx. This is where there's even more recordings. So wanted to show you that. The description will have the information, but have a great rest of your day. Have a great rest of the week. And I look forward to seeing you again real soon.